Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Sam Urrutia, who is assistant professor in the Division of Oncology at Washington University. And we are going to talk today about low risk MDS, some of the new data that came up at the ASH meeting in 2024. And then I'll ask Sam about how he uses this data to inform his practice. So, welcome, Sam.
Thank you. Thank you, Ravi, for having me. I'm happy to be here.
So, Sam, first of all, I think we're going to talk a little bit about the command study. Could you, for the audience, tell us what exactly this study was, and then we'll review the results.
Yeah, so this was one of the largest low-risk MDS studies. It was a randomized trial between luspatercept and a classic treatment of low-risk MDS, epoetin alpha, dosed at maximum doses. So this looked at patients with low-risk MDS. And back then, we didn't have IPSSM, so it used IPSS-R to divide patients between low and high risk. And also, patients had to have EPO levels less than 500 to be enrolled in this trial. As you all know, patients who have EPO levels that are higher than that shouldn't really be getting in any EPO at all. And so, as a part of the randomizing strategy, is patients who would have at least some opportunity to respond to EPO. And then the main analysis was 12 weeks, sorry, 12 weeks of transfusion independence was the primary endpoint of this study. And what this has been presented before, and the drug has been approved by the FDA for use in low-risk disease. But what we had this year was the update of how long the responses were. So responses of transfusion independence at 1 and 1.5 years after starting treatment.
So, what was the demographic of the patients accrued to the trial?
Yeah, so this is how our population in MDS looks. As you know, it's all mostly 69 to 70-year-old people. And then the important thing here to see is that the amount of transfusions these patients needed. So this is for only transfusion dependent people, so at least needing one transfusion a week. And this, you can see here, 4 units in 8 weeks is the majority of patients, less than 4 units, but at least one. And then more than 4 units is what we considered high transfusion burden. And then patients did not need to be SF3B1 mutated. So this is a main difference between this one and the prior study, the Medalist trial, that was a randomized controlled, placebo-controlled trial where patients needed to be SF3B1 mutated. This was not the case for this one. And so we had patients with SF3B1 mutation, which correlates very closely with ring sideroblast, as you can see here in the bottom to the right. But not all of the ring sideroblast patients are SF3B1 mutated. This is also different from the regular low-risk MDS population. I would say that it's probably 50-50 between RS positive and RS negative. So there was a little bit of bias towards SF3B1 RS positive patients that were accrued in this trial, possibly because the investigators knew that patients with SF3B1 mutations respond better to this compound.
So, what were the responses?
Yeah, so this is actually very impressive. We have never seen responses like this as far as transfusion reduction in any of the other drugs that have been tested in low-risk disease. So that's huge, right? 76% of patients had transfusion independence by 12 weeks. And out of those, 44% still continue to be transfusion independent at 1 year. And out of those, 30% continue to be transfusion independent at 1.5 years, 18 months. And so you can see that some patients drop off as is expected because this is a clonal disease that evolves with time, new mutations arise, and patients tend to progress either to a higher risk disease or either just stop responding to the previous mechanism that we used.
So, and do all the patients benefit? Are there subsets that do better?
Yeah, 100%. So patients with lower EPO levels tend to be, in general, better responders to anything we give them. So it can be luspatercept or EPO. So the lower your EPO level, the higher your response will be to any of these compounds. But as you can see there in the first red box, more patients with luspatercept responded in general. So you can see that effect also happening between both EPO and luspatercept. The wild type patients, the SF3B1 wild type patients, RS negative patients, do respond a little bit better, but just my own opinion here, I think this is still out there. And many of these patients if we use the updated calculators of risk now, they would now be probably a little bit of higher risk just based on their mutational composition. So that may be the reason why they don't respond as well. I think with for the RS negative patients, that is the population we really should focus on now, on trying to improve their transfusion independence and trying to improve iron overload and or the other problems in the future. Because even though we can see some responses here, and this is still indicated in RS negative patients, we can expect just less responses and shorter responses in them.
And how safe is the drug?
Yeah, so I'll say that there were two concerns at the beginning when this was under development, and one was asthenia, and patients are anemic, they're needing blood transfusions, they get pre-medications for the blood transfusions. You never know where it's really coming from. So some patients say that it's right after the drug is given, or a week later, a few days later. So that's hard to tease apart. But it does seem to be a little bit of higher risk of fatigue or asthenia with this drug. So we need to be careful with that. The good thing is that this seems to be something that uh, goes down with time as treatments go by and maybe patients get a response, it seems to get better. The other concern was high blood pressure, and this was also seen at the beginning and seems to ameliorate with time, which is a positive thing. We don't want to add more problems to an already elderly population that may have cardiovascular risk factors, adding hypertension to it. So overall, and another minor thing would be that I think it's not listed here. Oh yes, it is. Injection site reactions. There are a series of pre-medications that are now in the label for luspatercept too, so we can avoid these problems. But overall, it seems to be safe, well tolerated, and it doesn't seem to have any long-term effects that we know of now to this data cutoff of 2.5 years.
Hey, so let's move on to another study, the GFM Combola study. This
Yeah,
too
this
was presented at ASH. So what could you tell us about this trial?
Yeah, so this is really getting at that first point I mentioned. This is from the Francophone group in myelodysplastic syndromes from France and Canada. So the patients who are RS negative and patients who stop responding to EPO, those patients are really hard to get to a response again. And so what the investigators here thought was, why don't we add luspatercept to EPO and give it at the same time? And so they did a classic trial where they just were finding the optimal dose to test with along with EPO and luspatercept, and they went with the highest dose. So just so you see here, 1.75 is the highest dose of luspatercept that is currently approved to give. And this is actually something that's being studied now to see what the optimal dose is. The usual starting dose is 1 milligram per kilogram. Now, the EPO doses here also went up to the highest because these patients are also thought to be kind of less of responders than compared to the SF3B1 mutated RS positive group. So they were just trying to maximize the amount of patients who would respond by going with the maximum doses currently approved to be given safely to all of this population. That's what they were going for.
And so what again were the characteristics of the patients that were accrued that you would like to highlight?
Yeah, so this is when it gets really difficult here, because you can see here MDS risk. This is IPSS. So it does include cytogenetics. It doesn't include any of the mutations. If there are many publications about this, but if I were to convert this intermediate one group now to IPSS-R or IPSS-M, they would most likely convert to a higher risk disease. So I think they enrolled patients with high risk disease just because of the characteristic of these patients. They have failed EPO, they are now transfusion dependent, and maybe their numbers seem to be lower in general. Platelets 94, median white count goes down to 2.9. So these patients are higher risk patients that were transfusion dependent, but not yet high risk disease by IPSS. Now, again, if I were to convert this to updated calculators, maybe they would be higher risk patients. So I am actually impressed about the results of this trial.
We'll review the results in a minute, but what about the safety of the approach first?
Yeah, these are two drugs now. So luspatercept we've been using now for 5 years on trial, and now it has been approved for the last 2 years. So the safety profile is kind of well understood now and expected. And EPO, other than the probable risk of thrombosis that wasn't seen here, The safety was really not an issue for them. It is interesting to see that the reasons for death were infection, so that's more of a high risk problem. And also there was an AML transformation going again about this is almost never happens in SF3B1 mutated patients. It's very rare. So the fact that there was an AML transformation also speaks to the population that we're trying to enroll.
And the results then?
So it was dependent on the amount of transfusion burden. And it's also something we see. So the lower your transfusion burden, the better your response will be, because being transfusion independence from 4 units a month to 2 units a month is going to be much faster, right? But overall response, and this is very stringent, right? So it was erythroid response by the 2018 criteria, which is something that luspatercept commands did not use. They used the 2006 criteria. And so this is 25 weeks of transfusion independence. So that's really, really good. So 30% of patients responded to this. So I think that this really tells us that there may be something here worth looking into further, especially for higher risk patients who are not yet high blast or increased blast. And this may be an option for them, or to patients who under respond, or to rescue responses from patients.
Okay, moving on to another trial that was presented, elritercept. What is this?
So frame by frame, it's almost the exact same thing as luspatercept, okay? So it's still activin A, and it's activin receptor type 2A. So it's the target seems to be the exact same thing as luspatercept, and we'll see in a moment why that's the case. But just to to give some background on this, so the first compound that looked like this was a activin A and activin receptor type 2B called sotatercept, and that was the very first drug that was developed. I think what may have happened is that the company went the other side, and that drug, sotatercept, is I think soon to be approved in something completely different, right? Pulmonary hypertension. And now the other compound that was in that pipeline was luspatercept, and now that seems to work by inhibiting growth differentiation factors. At least that's one of the possibilities. But I think in reality, nobody really knows how it works, because there have been some other studies looking at downstream from the purported effect of luspatercept, knocking out some of those pathways, and it doesn't seem to do the same thing. So I don't think we exactly know how it works. But elritercept is a very, very, very similar drug to luspatercept. The good thing about this is that they are using the new response criteria from 2018 to look at transfusion independence in this early phase 2 trial. For the phase 3, I'm sure they will be mandated to use the 16 and 25-week endpoints.
And so, what again were the patients like on this study?
Very similar to Medalist, the randomized phase 2, and also very similar populations with more patients with RS than we usually see in practice. The transfusion burden was pretty high in this group, so 60% high transfusion burden. And the IPSSM, IPSSR, now they can be used. So this is a modern trial with modern calculators of risk. And so most of the patients were very low, or intermediate low, or moderate low. But there were a subset of patients who were higher risk.
And were any signals, any red flags regarding safety?
Yeah, the main thing with the main thing here with safety is this three deaths that are closely linked to cardiac problems, right? So heart failure, myocardial infarction, and sudden death, which usually seem to be secondary to myocardial infarction. So the the degree of high blood pressure with this study has not been published yet specifically. I think there was a 15-16% reported, but it hasn't been said how much of that it was. So we don't know yet about that. This is early data, and the deaths in low risk MDS shouldn't be that common. But this is what we've seen so far, and I think we should investigate this before continuing forward.
And what were the efficacy results like?
It's very interesting because if you look at Medalist, the very first luspatercept trial, this TI at 8 weeks, which was their endpoint in that New England Journal paper, is exactly the same. So
Interesting.
I anticipate very similar results from this drug.
And I guess patients felt better if they responded.
In general, yes. The patient-reported outcome, folks. This is obviously the most important part of this because most of these patients will not transform to AML. Most of these patients may not need transplant right away. So just improving their quality of life with the medication is important. Uh, in the Medalist trial within the placebo, so it was placebo versus luspatercept, they looked at these scores, and whenever patients would come in for an injection or a transfusion, their scores seemed to improve. And so many people were saying, well, if you're just doing a transfusion, why do you need to give this expensive medicine? But the fact is that when we look at this FACT score, so they look at many things, not only fatigue or asthenia or constitutional symptoms. They look at quality of life and time spent in the hospital. They look at their other activities that patients do. There seems to be a consistent improvement. It's not as high as we would have expected to be for patients who are getting transfusions versus patients who are not. But the signal is there. I wish we could have a better way to assess this, but this is what we have so far, and I think there is some improvement in these scores.
Okay, and the last abstract I think we're going to discuss is about imetelstat or Rytelo. So could you tell us about this presentation from the ASH meeting?
Yeah, so this is an interesting story because imetelstat is really one-of-a-kind drug. So telomerase inhibitor, lots of people were interested in this forever. The company it was a anti-aging company to begin with, and then they transitioned to this. So everyone thought that there was something to do with the telomerase, and maybe if we lengthen them or shorten them, then we will age less rapidly. So that was the whole idea behind this. But when they were doing their studies, they saw patients would have myelosuppression, and then they would have increases in their previous numbers, and that's what led them to try to develop in this space. So that's an interesting story. The IMerge study was published, I think, last year, and this led to an approval. So crazy year for MDS, no approvals for, I don't know, 40 years. EPO was really not labeled indication. It was more of an off-label use. But now we have two more drugs, imetelstat and luspatercept. The main thing with imetelstat is that it is a myelosuppressive medicine, so it does cause neutropenia and thrombocytopenia. Most of these get better after a few weeks after the dosing, and then patients do become transfusion independent, or their transfusion burden improves after that. And the trial that was presented, or the study that was presented on this ASH, was a combination of all of the patients who were treated in the early phase 2 and then the phase 3 trials to try to get to what is the overall efficacy and safety of this compound.
So what did this pooled analysis show? Like who were the patients on it first?
Yep, it's our patients, right? 70-year-olds, patients mostly with RS positive disease as well. And then they had IPSS low and intermediate. So again, because it's IPSS, those intermediate patients will probably be bumped to higher risk if we use modern calculators. They also looked at transfusion burden. So these patients had a higher transfusion burden compared to the luspatercept and then elritercept trials. And then many of these patients have had prior history of using many agents. So ESA, lenalidomide for 5-cube, luspatercept, and even HMA. And then they looked at the number of cycles that patients were able to receive.
And what were the results?
So if we separate them by patients who have had previous treatments, I think this is where we really get the important information here. So there are patients who had previous ESA, top right, and then patients who had several treatments. And this is where it's really encouraging to see. So if you receive this as first-line treatment, which many people may be wary of doing, right? This is a patient with low-risk MDS. They need one transfusion a week. and you can give them luspatercept or EPO, and then that maybe improves, right? But it may be a different deal to give them imetelstat, which will require once or twice lab checks during treatment, so more like HMA therapy, and will require transfusions in the middle of treatment. And it's a kind of higher impact, quality of life impact to the patient to give something this upfront. So with first line imetelstat, you get an 8-week transfusion dependence, 54%. So that's a little bit higher, and this is a small number of patients, but it's a little bit higher than luspatercept, right? But the encouraging thing here is that if you have received luspatercept before, or you have received ESA before, you still maintain a decent transfusion independence outcome, 42%, 30% for 2 prior lines of therapy with imetelstat. And the other encouraging thing here is the 24 weeks. So again, this is the stringent IWG 2018 criteria point. After 1 prior line of treatment, which for most of these patients was already luspatercept, they still have a 30% transfusion independence that lasts more than 6 months. So I think that's remarkable.
And anything to add to what you said in terms of the pooled analysis?
So I think the interesting here is this. So usually the usual course of treatment for patients with low-risk disease that have not progressed to high-risk disease will be either EPO or luspatercept at the beginning. I think for SF3B1 mutated patients, luspatercept should be the way to go. The amount of transfusion dependence you get, the average weeks of transfusion independence you get is much longer. After that, in general, people would want to try either HMA at a lower dose, or they can try something like imetelstat. And so the fact that these patients, so we have 20 patients here on the top, on the rightmost column, sorry. The fact that they were able to get to an HIE by 2006, which is just 8 weeks, right? And an HIE 2018, which is 16 weeks, 23% after HMA. So you were able to rescue response in 1/4 of patients. I think that's very good. And after luspatercept was still 30%. So I think that as you have seen in myeloma for sure is we hope that in MDS we'll get to that point where patients have a response long enough for the next development in the disease to come up, and maybe they can continue to have good responses over a period of time. And I think that we're starting to see which may be the best way to sequentiate these treatments from luspatercept to HMA or imetelstat, doing that one before the other. I think that's the next big question.
And what about the side effects of this drug?
Yeah, this is where the problem comes, right? So the side effects, I think all of the hematologists who treat MDS or AML are very aware of the side effects and can manage them easily, and it's something we do every day. But 70% neutropenia, 70% thrombocytopenia, and most of these go away, but it still requires close monitoring. I wouldn't say that it requires as close monitoring compared to luspatercept. So this requires closer monitoring. I do get labs twice a week, and patients sometimes need platelet transfusions, and patients may need dose reduced cycles in the future. And this is less likely to happen with luspatercept. And as our objective is to try to reduce as much the hospital burden of the patient having to come to the hospital for lab checks, for things to do, for transfusions, then I think this is better reserved for luspatercept failure.
Okay, so in terms of just summarizing what the key takeaways from the ASH abstract is, what would you say?
Yeah, I would say that long-term responses of luspatercept are encouraging for patients who are not quite yet high-risk MDS. Maybe the combination holds some promise. I think we do need to see more data on this. Important to have an option after luspatercept failure with imetelstat. And elritercept, I think, would be another option. Hopefully there's some competition and the prices can come down between this and luspatercept in the future, but I think it's looking promising so far.
So now just to before we end, how do you approach it? What's your algorithm? When you see a low risk MDS patient, how do you go about deciding what to do?
Yeah, I think the having cytogenetic and mutational data up front is the most important thing. It's what's going to inform you the most, more than the blood counts, more than the blast count, more than anything. Some low-risk patients are in a transition period in the first 3 or 6 months, and they can progress very quickly to high-risk disease. So I'm thinking monitoring those first 3 months and then those 6 months later with bone marrow even, the 3 to 6 month range would give us an idea of the tempo of the disease, of how it's progressing. Some patients, especially the SF31 mutated patients, just stay stable for years. Nothing really happens, and they can have a hemoglobin of 9 or 10, never need transfusions for years. So I think understanding first the tempo of the disease is important. Once we have established that, if the patients are transfusion dependent, then and then SF3B1 mutated, there's no question in my mind that luspatercept should be the first-line therapy for those patients. They're just going to get a lot of mileage out of it, and they're going to feel better. And the side effects are minimal, and we can manage. As second-line therapy, I guess this is where there may be some controversy because I feel very comfortable using low-dose HMA in those patients and getting them transfusion independent again, and thinking about transplant and planning it out. I think a very valid option too is using imetelstat after luspatercept. And so I think we should know that. So that's the algorithm for SF3B1 mutated patients. For patients who don't have this mutation and have low-risk disease, I think in general they progress much more rapidly. They usually have other splicing mutations. And so getting them to transfusion independence with either luspatercept or EPO is okay. If patients run into trouble with insurance with luspatercept or anything like this, I think EPO is acceptable, and there's always the option that they will then be able to receive luspatercept. In those patients, I'm more, especially if their counts are coming up or the blast counts going up, I'm much more an early adopter of HMA therapy in the RS negative patients, but I don't think we know if HMA versus imetelstat is better. I don't think we know that. There is a trial right now in AML and high-risk MDS with imetelstat that was partially presented with some disappointing results. I thought they would be much better, but that's still yet to be seen. And then the big question about low-risk disease, since many patients are going after a cure, is whether to do transplant or not. The general recommendation has been not to do it based on some Markov analysis several years ago. But now there may be some new data showing that in patients who are rapidly progressing or in patients who have a certain type of mutations, thinking about transplant earlier is better, just because as time goes by, there may be more complications, or patients are not really getting any younger as time goes by with low-risk disease. So there may be an appropriate time to do it, but that's still an evolving question, and we're probably not going to see a clinical trial that's going to give us a response to when would you transplant a low-risk disease patient, because we know this is not going away. But as I said at the beginning, knowing the tempo of the disease, how quickly it's moving, I think it's very useful to know, to be able to make that decision together with the patients.
So one question about management. Do you take into account the EPO level at any point in your decision making?
I use it as a informing point to know how good the response will be or how quick. The thing with luspatercept is that it's not like chemotherapy where you give it and you're going to have a response in the following day. You have to give it, and sometimes you have to escalate doses until patients respond. So I know that EPO high patients will just not respond to EPO, right? So more than 500, the responses are, I don't know, 1%, 2%. Between 200 and 500, which is what they enrolled in the trial, I think there may be some 15 or 20% of patients who will respond. But for the majority of 500 and up, the best responses we see with luspatercept. That's another group where I would say maybe in RS negative patients who have high EPO, it's better to try luspatercept than EPO, 100%.
That's one place. And where do you place lenalidomide in your algorithm for low risk?
Yeah, we didn't talk about it because most of these trials have excluded these patients since they have very good outcomes with lenalidomide, and they can be transfusion independent for many years. I think the big concern with okay, so there are two ways you can use lenalidomide. The initial way was you're transfusion independent, usually younger females, right? Younger females who are transfusion dependent, they have a 5q deletion. And so lenalidomide has lower doses than used in myeloma has been shown to work to reduce transfusion dependence for many years. The problem is what we've seen is that the use of lenalidomide sometimes in some patients who may have small p53 clones may make them show up in the future. And usually that happens at the time they lose response. That combined with Sintra-Rev trial from the Spanish group showing that you can start lenalidomide when patients are not transfusion independent, but just when you find it, is also beneficial for survival. So we're starting to use it even before transfusion dependence now. And I think that makes sense from a avoiding transfusions, iron overload, and all the complications in younger patients usually. So I think that would be first line for patients with 5q deleted MDS. And then after that, there are other options, but that would also depend on why they stopped responding. And usually for most patients, that why is because of p53 mutations.
Interesting. So you mentioned using these drugs in transfusion-dependent patients, but there are several patients who are between a hemoglobin of 8 and 10. Do you treat those patients with any of these drugs?
So you'll see that for the SF3B1 patients, they have been anemic probably for many years, and they just found out at some point that somebody said, "Hey, let's do bone marrow. Maybe there's something wrong." And so those patients are very well they get used to their anemia, and so they don't have that much symptoms, and they can do many things. And so if they are feeling well, and maybe they're not needing they're not needing any transfusions to feel better, I may say, well, maybe we can just observe you and see how you do, and if this gets worse, we think about treating you. But for patients who are kind of more rapidly progressing towards anemia, they feel it more. And so we should definitely discuss that with them. It's not an approved indication. And I think at some point these patients need transfusions, and as soon as they do, you could start treatment with luspatercept or EPO or lenalidomide in that case. The development of luspatercept is moving towards that group you mentioned. So it's moving towards transfusion independent people with anemia. So that's going on right now. Now, when people hit 11, we cannot dose it anymore, hemoglobin of 11. But all the development of luspatercept is going now looking at transfusion independent patients. And I think that's important because there was another study in ASH called the Predator study, also from the French group, looking at EPO before transfusion dependence. And they found no difference in survival or time to first transfusion. And so it would be very interesting to see if with luspatercept we can avoid patients becoming transfusion dependent much sooner.
Well, I want to thank you very much for that really exhaustive coverage of low-risk MDS, and this has been a great session. I hope I can turn to you in the future for other recordings, and as new data becomes available, really wish you a big thank you.
Thank you so much, Ravi, and thank you all.
Thank you.